வந்துருச்சு. டாக்டர் ஜெயக்குமாரும் ஜாயின் பண்ணிட்டார். CGP மெம்பரா தானே?
எதுக்கு அதெல்லாம் போட்டுட்டு இருக்கோம்?
போனா அது கேக்குது.
முதல்ல ரிசர்ச் பண்றீங்களா?
நீ இது கேட்டது லிங்க்குள்ள போனேன்.
பே பண்ணிட்டேன்டா.
அக்கறை தாண்டி பே வரல வந்துட்டுமா?
வந்துடுறேன்.
சரி நீ போடுங்க மட்டும் போயிட்டு.
Not this way. It's like jump. Hello. Hello.
Hi, Bhajan.
क्या था YouTube में सदगुरु था.
Tell me where you start. அது கேக்கலையா சார்?
இதுல கேட்கல, இதுல சத்தம் வருதா?
இந்த வெளியே வரலையே.
வரல.
வெளியே வரல.
Hi, my name is Sunita and I completed my engineering in 2018. When I came across the program, I just knew I needed it because many things were going on. It was a rough patch. I kept all.
இது வந்து ப்ளூடூத் கிடையாது சார், ஓபன்ல கேக்குறது. ப்ளூடூத்ல கேக்குறதுனா உங்க பேரை கேன்சல் பண்ணிட்டு இதுல பேர் பண்ணனும்.
ஆமா, இதுல பேர் பண்ணனும்.
பேர் பண்ணா உங்களுக்கு கேக்குது.
இல்ல இப்போ இது வந்து
there is no limit as to how a human being can become.
இல்ல அது வால்யூம் குறைச்சு, ஆமா வால்யூம் குறைச்சு.
This is something that every human being must.
இது கேக்குமே, அது கேக்கலையா உங்களுக்கு?
இதுல கேக்குதா?
வெளியே கேக்கல. உங்களுக்கு கேக்கலையா?
எனக்கு கேக்கல. அது
வெளியே கேட்கல.
கேட்கல, அதெல்லாம் கேட்கல.
I'm here. When do we start? Let me know. I'm Dr. Nagaraj, okay? I'm here. I'm waiting.
இப்போ வருது.
வருதா?
தனுந்து டேய்
Put the mom at the time, volume coming in.
Researchers at Harvard Medical School have found
What I know, the coming.
studies at Rutgers University show
It will be
that
clear.
inner engineering online results in significant increase in energy, joy,
Okay.
mental clarity,
இது ஓகே பா. இப்போ இது எவ்வளவு நேரம் டார்கெட்ல போகணும்?
இப்ப 3 மணி நேரம் போட்டுருங்க சார்.
ஆ.
இப்ப போட்டுருங்க. 3 மணி நேரம் போட்டுட்டு 3 மணி நேரம் அப்புறம் நீங்க யூஸ் பண்ணிக்கோங்க.
3 மணி நேரம் கழிச்சு இப்போ நான் எடுத்துட்டு
எடுத்து மாட்டுங்க.
ஒண்ணு எடுத்துட்டு மாட்டணும்.
மெதுவா எடுங்க. ஒண்ணும் பிரச்சனை இல்லை.
The post-related conditions or in certain conditions.
Ramesh Babu Sendil. Hello.
Problem. No, stop, sir. No problem. No problem.
Hello.
Hello.
Dr. Sendil.
When do we start? The phone call. Hello. When do we start? Hello. phone for me.
Sir, shall we start, sir? President, sir, shall
Ready.
we start, sir?
Yeah,
Yes,
I'm
sir.
ready.
Dean,
Yes.
sir? Yes, sir.
Start.
Fine, sir. So, Dean, sir, are you ready, sir?
Ready, ma'am.
Yes, sir. Fine, sir. Thank you, sir.
Hello.
Sir, Dr. Dhiravim, sir?
Yes, sir. Yes, sir.
Yes, sir. Fine, sir. So, good evening, all. So, today we are going to have our national CGP CME, and our secretary, Dr. Anbarajan, sir, will join us shortly. So, until then, I will be just coordinating the meeting. And now I request Dr. Dhiravim Mohan, sir, Joint Secretary, CGP Headquarters, to give IMA prayer.
Good evening, all. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
Sir, kindly proceed with vision prayer and flag salutation also, sir.
Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skills to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me the singleness of purpose, strength to lift at least a part of the burden on my suffering fellow men, and a true realization of the privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you. Flag salute. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be your light and strengthen, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as aggregated members of this national organization, we sure we will dedicate everything in our power to see it fly high in the committee of nation. Jai Hind, long live IMA. Thank you.
Thank you, sir. So now I request our Dean, Dr. Rayappa Ramesh Babu, sir, IMA CGP Headquarters, to give his welcome address. We welcome you, sir.
Thank you, Dr. Sendil Kumar, and respected National President, Dr. Sharad Kumar Agarwal, sir. It is really an honor for CGP IMA Headquarters always getting a greetings and inaugural speech by our National President, Dr. Sharad Kumar Agarwal, sir. And also, I congratulate the CGP Tamil Nadu branch for organizing continuously these educational programs. And it is really very great. And they're also getting the creditors from the Tamil Nadu Medical Council. Actually, the concept of educating the primary care physicians is very important nowadays in this country, because these are the key people are going to handle all sorts of cases, including all specialty, super specialty at their primary level. So it is most important for them to know about each and every department and specialty, super specialty, and emergency cases, how to handle those cases and how to send with good standing towards to their specialty people and super specialty people. At the outset, in the 24th also, we will be having extremely a international conference on emergency medicine and the role of primary care physicians with a renowned international faculty and faculty. This is only to update the knowledge of the primary care physicians in emergencies. So I've been watching the CGP in Tamil Nadu state. They're doing excellent work, and excellent. They're just selecting the speakers also, very renowned and eminent speakers. And it is very happy to know that even though they are very renowned specialists, they are coming down to a level of primary care physicians and just giving a talk to educate them at their primary level is really, really very much appreciated things. I congratulate Dr. Sendil Kumar and Dr. Amburajan sir for having such a programs. I hope in future also they will have more number of CGP programs under the Tamil Nadu CGP. Thank you for the opportunity given. Thank you, Dr. Sendil and Dr. Amburajan sir.
Thank you, sir. Now I request our National President, Dr. Sharath Kumar Agarwal sir, to give his presidential address and also inaugurate the session. We welcome you, sir. Sir, Dr. Sharath sir, can you just...
Yeah, am I audible now?
Yes, sir, audible, sir.
Yes, sir. Yes, sir. Yes, sir.
Respected National President-elect Dr. R.V. Asokan sir, Honorary Secretary General Dr. Anil Nayak sir, respected past President Dr. J. Jayalal sir, all the past President, dear Finance Secretary Dr. Kshitij Bali, Dr. Ramesh Babu, Dean of CGP Headquarter, Dr. Amburajan, entire leadership of Tamil Nadu, and dear friends. First of all, I must congratulate this year the CGP team led by Dr. Ramesh Babu and very efficiently executed by Dr. Amburajan. They both have lifted the standard of CGP to a next level. The continuous program organized by this team online, they are par. They have organized a training program on almost all kind of subjects. And this is what the role of IMA CGP to keep updating our family physician, our primary health provider, clinicians on different kind of diseases and advanced and the emergencies. I am fortunate to be part of so many CME they have organized throughout the year, and that is why I know the good work they are doing. Today's summit on ONCO update is again a very important topic, though it is mainly handled by the super specialties. But the knowledge of ONCO to a family physician is very important for, and they are the first step of the healthcare. They are very close to the society. They are very close to the community. And if they have been trained on the ONCO screening, so more and more patient of ONCO, they can be screened in the early stage and will be benefited by early treatment. Because if the family physicians are trained and how to diagnose and when to diagnose and when to send for the specialist, then more and more community and the cancer patients, they will be benefited. So I am again congratulating entire team and my best wishes for the success of their CGP, this particular conference, and continue to organize. And Tamil Nadu branch is very active in organizing all these things. They are very, very active in organizing online as well as the offline CGP programs. My congratulations to the Tamil Nadu team also, the President Dr. Senthil Pari and the Tyagarajan, the Secretary, and the entire team of Tamil Nadu. With these words, I again congratulate the CGP team. Long live IMA, Jai Hind, Jai Bharat.
Thank you, sir. Thank you so much for your kind words, sir. We will keep up your expectations in future also. Thank you, sir. Now I request our Honorary Finance Secretary to give his address. Dr. Kshitij Bali, sir, kindly come towards, sir. Yes, sir.
Thank you, sir. It's a good afternoon from Delhi. I'm really happy with the work which has been carried out by CGP. Recently also we had gone to Karnataka to experience a CGP conference which was done by the Karnataka state. It was really awesome, and it's really good work which is being done by the team right now. And I would like to give regards to our National President, Dr. Sharad Agarwal sir, to our HSG, Dr. Anil Nayak sir, to Dr. Jailal sir, our past National President, and also special thanks to Dr. Asokan sir, if he's around, President-elect. And a special thanks to Dr. Ramesh Babu, the Dean of CGP, to Dr. Poonam Singh, the Vice Dean of CGP, and Dr. Amburajan, the Secretary of CGP. It's a very important topic about oncology, and the role of a GP is paramount and important because they are the ones who are basically seeing these patients who are presented to them with, vague symptoms and early detection, catching these patients early, referring them to a specialist is important because early detection can lead to good quality of life and, less amount of surgery which is required for these patients. The role of GP is for detection, as already mentioned by our National President sir also. There is risk assessment also because the GP knows about family history of a lot of patients and the families around. So they would be aware of patients in which, the oncology or the cancers is running in the family. So they can, counsel these individual patients, tell them, brief them, warn them about their chances of developing cancers and recommend them preventive measures and screening also. And they are involved with counseling and educating of the patients also. The GP can provide information and counseling to patients about cancer prevention, lifestyle modifications, and role of regular screening. There are very simple OPD basis screening tests which can be easily done by GPs like mammography, pap smears, colonoscopies can be done. I am practicing urology, so a simple test like a total PSA can be done, and all these patients can be, screened and referred early. GPs are also involved with symptomatic management. All these patients who have got symptoms related to treatments of cancers, so once they've got a treatment done, they're undergoing chemotherapy or something, all these side effects like nausea, vomiting, and everything. So all the GPs can provide, palliative treatment to these patients. Even palliative treatment, advanced cancer patients in which you can do nothing beyond. So the GP is involved basically for emotional support and even symptomatic support. And the role of GP is important for a follow-up surveillance also, because once a patient has been treated and cured, so-called cured by cancers, they're very comfortable that, it's gone. But we all know that the incidence and the recurrence is more after 5 years, especially. So even after a successful cancer treatment, GPs can monitor patients and address long-term effects of cancer treatments and also look for early recurrence so that these patients can be warned to take, early treatment. And the GPs are most important to diagnose and refer these patients so that, a good treatment can be done. And I'm happy to see that, all information about, the topics which have been taken today are of paramount importance to GPs. And I wish the conference all the best. Thank you so much, sir. Thank you, sir.
Thank you, sir. Thank you, sir, for your kind words and wonderful motivational regarding the oncology update. I request our National Vice President, IMA, Dr. Jayesh Lile, sir, to give his felicitation.
I'm audible. Hello.
Yes, sir.
Yeah.
Yes, sir.
Thank
Audible,
you.
sir.
Thank you, Amburajan. Our respected Honorable Sri Dr. Sharad Agrawal, sir, National President, Dr. HSG, sir, Dr. Anil Kumar Nayak, Dr. Kshitij Bali, and the entire team of the CGP. And of course, Tamil Nadu is very, in the CGPs, so many doctors are there. I can see joined nearly 470 delegates attending this very important conference. ONCO update for the family physicians is very important. And as Dr. Kshitij and Sharad sir has mentioned, in a diagnosing to guiding the patients, relative patients, and then taking them to those whether surgery, onco or chemo has come a long way. What we learned 25, 30 years back, day in and out, new things are coming, new horizons are opening up, and definitely the cancer survival has made a great history, and definitely the doctors are realizing that this very important gamut, what we have, the tool that is chemotherapy, radio, and modern gadget, new operations and all, is going to be really helpful for the patients and the relatives and the families. So keeping update to the family physician is very, very important, because I myself, being a family physician, I'm aware of the day-to-day, how the patient diagnosed and how they are panicky when they come to us. And the once we tell them that, oh no, sorry, your disease is such, and then they realize, but then we need to give them entire gamut of battery of investigations and tests, and subsequently follow up in the treatment, in the palliative, and whenever the patients they are operated or they are given that at home, we need to give them care at home, maybe putting a Ryle's tube or putting sometime catheter or putting sometimes the stomach killing is there and all those things. So really today's important things of oncology, when the see that the life expectancy has increased, and so also the malignancy. So the role of family physician in the onco update is very, very important. And I'm very happy that this entire important topic has taken up by the CGP. And I really wish the entire team's great success. We look forward to have more and more small conferences like this. Over to you, Dr. Anburajan, sir. Thank you so much.
Yeah, thank you, sir. And now we move on to the CME program, and I'm very much happy. Yeah, sorry for the interruption. And now I am very much happy to introduce our moderator, Dr. G. Nagaraj. He is the Chief Division of Radiation Oncology, Dr. Balabai Nanavati Hospital, Mumbai. Sir has finished his MD in Radiation Oncology, AIMS, New Delhi, and DGO in College of Physicians and Surgeons, Mumbai. And Sir is part of several national and international affiliations like Association of Radiation Oncologists, Indian Association of Medical Oncology, Indian Society of Oncology, Indian Association of Immunologists, Indian Association of Cytologists, so on, and many international associations like Association of Therapeutic Radiation Oncologists of America, Radiation Research Society USA, North American Hyperthermia Group USA, Asian Association of Radiation Research, and so on. Now, we are very much humbled to have you as a moderator today, sir. And I request you to introduce the speakers and start the session. Handing over the session to you, sir. Thank you, sir.
Thank you so much. Good evening. And I remember
sir, you are not audible, sir.
Can you all? I'm sure you all hear me. Yeah. So I have been a member of last 4 decades.
Sir, you are not audible, sir.
So can you hear me? Hello, can you hear me? Hello? Hello? Hello, can you hear me?
Yes.
So, right, good. So I remember for the last 4 weeks, and it is a great pleasure to be here. And oncology is transforming also on a daily basis. There are quite a few interesting technological innovations. The paradigms in medical oncology changed, the early diagnosis. Well, there are some controversies, but nevertheless, when we diagnose a disease early, the odds are always better. But the challenge is always to diagnose them early. And it's not very easy to diagnose all of them early. So there are quite a few complex problems and dilemmas in oncology, some process being solved and some still evolving. So I did listen to, I have a very different concept of family physician. For me, a family physician is it's something called Annie's hierarchy. It's a physician. It is like a all encompassing vessel within which subspecialties or super specialties inside. So, and that because comes the pain. So the responsibility is not only to connect the dots which the specialist or the specialist create, but to hold the patient in a warm embrace knowledge and empathy. And that's why family physicians, even in the era of contemporary, where medicine still have lost edge, is still very relevant. And as I said, there are so many changes here. Artificial intelligence, immunotherapy, linear accelerators, optical accelerators, checkpoint inhibitors, you name it, CAR T cells, name it, things are just happening. So without any further ado, we'll introduce Dr. Mahmoud Ibrahim. He's going to talk on early diagnosis and surgical manager. Let us be brief of the introduction. And he's in PD India Hospital, Mumbai. He's a very well-known personality. Sorry, I think I got it wrong. So please run his data if you wish. That's right. Yes, Mohammed Ibrahim. He has done MS in surgery, MRC, and Hyderabad, DN surgical oncology, and he has been fellow from surgical Belgium. And he's a Europe board certified consultant oncologist. It's very long list, very long list. So maybe you can run that for benefit of those. I have the pleasure inviting him to speak, talk, and apprise all of us so that we can be wiser at the end of the talk. Early diagnosis and surgical management. Well, on to you, Dr. Ahmed Ibrahim.
Good evening, everyone. Thank you for the wonderful words, Nagaraj sir. So I'm happy that I am sharing the birthday with you, Feb 6th. Thank you so much. And I thank the National IMA Headquarters Office Bearers, National President, Finance Secretary for their wonderful words, and also National CGP, the Dean, the Secretary, for the wonderful arrangement of this topic, a very important topic on cancer, ONCO update for the general practitioners, which is very important, and also the need of the hour. So coming to the topic, so the topics today are like from diagnosis to recent advances. So I am a surgical oncologist. So I am from Tirunelveli, Tamil Nadu. So I'll be talking about the early diagnosis and surgical management of solid tumors. My contemporaries, they will be talking on radiation, recent advances in radiation, and also molecular signatures in medical oncology. So this is the ONCO update, and I thank the CGP for giving this opportunity so that we can share the recent advances and ideas in oncology management to the general practitioners. And this is my alma mater. That is Madras Medical College in Chennai and Regional Cancer Center, Trivandrum, where I did my surgical oncology. And coming to the topic, so cancer is preventable in most instances and is also curable in many more instances. 80 to 90% of the cancer are due to our habits and activities. Only 10% is due to genetic causes. And it can involve almost every part of the body. And cancer is nothing but it is multiplication of cells in an uncontrolled and haphazard manner. The cancer, as of now, it's almost the cause of 12% of all deaths. And in India alone, we have nearly 1.5 to 2 million cancer cases at any point of time. And every year, 8 lakhs new cases are being detected. And nearly 5.5 lakhs cancer patients die in our country every year. So, which is a very high morbidity. And facts about cancer, 70 to 80% are detected at a late stage when treatment is not possible. So this is the main idea. So if we increase the early detection, the cure rate will also automatically increase. So each tumor cell has a specific tumor biology which determines its response to different treatments, and also it has different prognosis. But what are the use of these statistics for a cancer patient? It's nothing, because for them, the most important question is whether the cancer is curable or not. And also, we must understand, will early diagnosis alone will cure all cancers completely? So to understand these two questions, we'll go through 4 clinical scenarios. And here, in the first scenario, a 48-year-old perimenopausal lady was diagnosed with a right breast lump in 2 months back. She had no habits and no family history. And on examination, it's a 7 into 8 centimeter lump in the upper outer quadrant and multiple mobile axillary nodes. An FNAC was done and it came as carcinoma. So a modified radical mastectomy, which is a standard surgical procedure, was done within a week of diagnosis. Histopathology came as stage 3 disease, and immunohistochemistry showed it is ER/PR positive and HER2 negative. And we did a adjuvant chemotherapy. She received adjuvant chemotherapy and followed by adjuvant radiation. And also she was given hormonal therapy also. But after 3 years, she had dyspnea, chest X-ray showed a right side pleural effusion, and the cytology showed malignant cells. So she was started on second-line chemotherapy, and within 2 weeks, she had disorientation. And CT brain showed multiple brain metastasis. Whole brain radiation was given. Patient develops cerebral edema and probably coning, and patient expires on the next day. This is the first case scenario. Second case scenario, all the cases will be on breast cancer only. So 31-year-old premenopausal lady presented with a 2 into 2 centimeter lump, a relatively smaller lump. FNAC suspicious of cancer, advised excision biopsy. So patient underwent excision through a periareolar incision to make a cosmetic outcome with no tagging of margin. The margin was not tagged, whether it is superior, inferior, medial, or lateral. So the histopathology came as infiltrating ductal carcinoma, but margins were positive. After that, the patient was referred to a cancer institute, and after evaluation, it's a non-metastatic disease. So patient wanted breast conservation. So breast wanted to be conserved, but due to contamination by the previous surgery, BCS was not possible. So patient was offered complete removal of mastectomy breast and reconstruction, but patient refuses the treatment. So within 3 months, patient presents with a fungating tumor in the same suture line, and re-evaluation showed she had multiple liver metastases also. Patient was started on palliative chemotherapy, and progressive disease, patient develops jaundice and expires within 3 weeks. Now coming to the third scenario, it's a 53-year-old postmenopausal lady, develops right breast lump for past 6 months, ulceration and foul smelling discharge for past 1 week. Patient has no habits and no positive family history. Patient belongs to an orthodox religious background. On evaluation, she was found to have a metastatic disease with right-sided pleural effusion, offered palliative chemotherapy, but patient wanted surgical removal at this infixed and inoperable moment. But patient denied treatment and started herself on alternative medicine and holistic treatment, and expires within a month due to metastatic disease. And coming to the fourth scenario, it's a 42-year-old premenopausal lady developed a left breast lump, and the FNAC came as carcinoma. On examination, it was 4 into 5 centimeter lump with a mobile axillary node, and no other metastasis was there. And modified radical mastectomy was done within a week of diagnosis, and the stage was only stage 2. Then patient was advised adjuvant chemotherapy and was referred to a cancer institute, but patient took first cycle and defaulted. Patient presented with local recurrence and multiple liver metastases within 5 months. She was offered palliative chemotherapy, and patient refused treatment and requested for pain relief alone, and she expires within 4 weeks due to liver failure. So in all the cases, all the patients had carcinoma breast in different clinical scenarios, and the final outcome was death. So we'll analyze what is the reason for the failure of treatment or failure to initiate treatment. In case 1, it was aggressive tumor biology and also advanced disease stage at the time of diagnosis. The tumor itself was a stage 3 disease with 7 into 8 centimeter lump. In case 2, it was patient's adamancy and inappropriate surgery for diagnosis. So initially there was an inappropriate surgery with a perianular incision for cosmesis. So cosmesis comes at the back hand when we compare cure in case of cancer. Cosmesis is not at all important if we consider cure for cancer. And patient was adamant that she doesn't want to lose her entire breast. In 3, patient's negligence and her poor knowledge about cancer. So she was having a religious orthodox background. She was not consulting the doctor early, and early delay in the diagnosis caused her loss of her life. And in case 4, even though the treatment was given correctly, there was inadequate treatment and patient's negligence. So in the initial time, when our president and National Finance Secretary were talking, they were mentioning about the role of family physicians and general practitioners in the early diagnosis. But here I should mention that not only early diagnosis, but also continuation of the treatment in cancer is very important, only with the cooperation of the family physicians and the general practitioners. Even if we write a investigation, they will definitely consult the general practitioner or their family physician to do it or not. And also if a treatment is suggested, it may be chemotherapy or radiation or surgery, they will consult the family physician and then only go ahead with the treatment. So not only the early diagnosis, but also the continuation and initiation of treatment is based on the family physician only. So if we look at the incidence of failures, case 4 failures, that is incomplete treatment, is the highest among all, which causes loss of life of our patients. And coming back to our previous question, whether the cancer is curable or not. So there are a lot of factors which decide whether the cancer is curable or not. So some of them are patient's cooperation, and it is the neighbor's cooperation, the patient's relatives' cooperation, and also stage of the cancer, tumor biology, whether the treatment was taken completely or not, and also appropriate treatment was taken or not. So there are so many factors which determine where the complete and successful treatment of cancer. So we all know the early detection of cancer is very important because cancer develops in the body very silently, and until it becomes to a certain stage, normal life without any complaints. And initially it produces only mild symptoms which need to be identified appropriately at the appropriate time. And why early detection is important? Because disease detected at an early stage produces better results on treatment, and also a cure is possible. Advanced disease shows poor result, and advanced disease leads to financial and psychological burden on the patient as well as on the family members. Early diagnosis is different from cancer prevention, and cancer screening is one of the best modality for early diagnosis, and no authorized cancer screening program is there in India except for cervical cancer alone. But cancer screening in Western countries, it is there for breast, cervix, colon, lung, and prostate. And in Indian perspective, the early diagnosis depends upon so many factors: patient's factors, initial treating physician factors, initial treating surgeons factors, oncologist factors, relative and neighbors factors, and tumor factors. So in fact, I have kept the tumor factors at the last. So patient's factors, whenever the patient sees any lump or bump, any non-healing ulcer, and any abnormal weight loss, abnormal loss of appetite, bleeding from any of the orifice, and any other subtle symptoms which comes new to him or her, and any family history of cancer or history of prior treatment for cancer. So in these times, he or she should be very, very vigilant, and they should avoid doctor shopping in these things. So initial treating physician factors, a patient may be having a hypertension or diabetes. So symptoms which are not related to those chronic disease, they should be critically analyzed. For example, a patient may develop a bleeding PR in an hypertensive patient. We should not consider that the bleeding PR is because of the hypertension or raise in BP. So we should do a rectal examination or refer for a colonoscopy to analyze the cause and origin of bleeding and to rule out a rectal or a colonic malignancy. And also we need to educate the patient about the seriousness of the symptoms and also the urgency to investigate. So this is the most important point I would like to highlight in this meeting. And also prompt referral to a cancer or hospital or institute if there is even a single doubt of suspicion. And coming to the initial treating surgeons, appropriate investigations for appropriate tumors. For example, a true cut biopsy is better rather than an excision biopsy for a breast lump with doubtful FNAC. So the pathologist may suggest to do an excision biopsy, but if the tumor is amenable for a true cut biopsy, only this has to be done. And proper excision biopsy techniques has to be done in excisable tumors without tumor contamination, and prompt referral for adjuvant treatment after curative surgery. In some of the instances, the patient may undergo surgery in a peripheral area, but they will not undergo an adjuvant treatment. In fact, they may not be aware that an adjuvant treatment has to be given or not, and the patient may recur with cancer within months or years. So that also has to be kept in mind. So this is a picture just to show how a proper excision biopsy has to be done. It is not a two-dimensional clearance, but it is a three-dimensional clearance as given in the right side picture. And this is an excision biopsy technique in a flat ulcerated tumor, and this is a punch biopsy. This most of the people will be aware of. And coming to the oncologist factors, we need to critically review all histologies, the histopathology report or the biopsy report, which is very important, even if it is positive or negative. In fact, negative histologies are more dangerous for an oncological perspective, because once an oncologist tells that the tumor is negative, is not malignant, then it is deemed as non-malignant always. And multidisciplinary approach has to be done. The surgical oncologist may operate, and once it is done, the medical oncologist or the radiation oncologist maybe have to be involved to complete the treatment process. And now comes the most important thing, that is the relatives or the friends and the neighbors factors. So whenever a tumor diagnosis is done, the final authority who gives the permission, it is the relative or the friend or the neighbor. So they always discuss about the problem which may look like cancer, and they need to encourage newly diagnosed cancers to start complete treatment without any default, and also avoid give any doctor shopping advice. And also they need to encourage, they should not discourage those patients and make them sick and psychologically bad. And coming to the tumor factors, we have most common. The most commonest symptom of cancer is it is asymptomatic. The tumor biology, it may be slow growing or it may be rapidly growing. And there may be sometimes tumors which may be resistant to all sort of available treatments, like an anaplastic carcinoma of thyroid. We don't have any available treatment for such very aggressive tumors. So how to detect the disease early? So the 7 danger signals are change in the bladder or bowel habits, sore throat, and unusual bleeding or discharge, thickening or lump in the breast or any part of the body, indigestion or difficulty in swallowing, obvious change in water or mole, or nagging cough or hoarseness of voice. I give a simple suggestion. If any person develops a new symptom which is not responding to any type of treatment for 2 weeks, then you should suspect cancer and do the appropriate investigation. So this is like a thumb rule to assess or diagnose cancers at an early stage. Now coming to the management. So the management includes diagnosis and treatment. It is the following steps are being followed. That is the confirmation of diagnosis. Next is the staging. Next, evaluation of the extent of the local disease, metastatic workup. Then comes the treatment, followed by adjuvant treatment and follow-up. So the main modalities of treatment is surgery, radiotherapy, chemotherapy, hormonal therapy, and targeted therapy. And the new addition is the immunotherapy. So surgery is the most commonest treatment. So the type of treatment is decided based on the stage of the disease, location of the disease, histology of the tumor, nodal spread, and also patient's comorbidities, and last comes the patient's preference. So no two patients will receive the same treatment even if they have the disease in the same part of the body. 2 breast cancer patients will not receive the same treatment, and it is always an individualized treatment. So if we compare the stage and treatment, most of the time it is stage 1, it is a single modality treatment, and in stage 2 it may be single or multi, and in stage 3 it is definitely a multimodality treatment, and stage 4 it will have a multimodality treatment and sometimes a palliative treatment. So surgery is the oldest treatment for cancer, and it is nothing but the complete removal of the tumor mass with negative margin. Here the tumor mass should be in toto. There is no role of piecemeal removal of the tumor. It is in toto, and it should be removed with the lymph nodes in case of carcinomas, and lymph node removal may not be needed in case of sarcomas. So use of frozen study for margin status and central lymph nodes should be available, and immediate reconstruction of the defect is necessary, and is also more critical in reducing the psychological morbidity of the patient. So here are some of the surgical pictures we'll be seeing. So we are not going to go into the technical details of the surgery. So here you can see a peroral approach for the removal of a carcinoma tongue. This is a simple wide excision for a carcinoma lip. And here you can see a soft tissue sarcoma shoulder on the right side. So the patient was advised initially a shoulder disarticulation, but we have done a reconstruction where the tumor was removed with the wide excision, and latissimus dorsi flap was harvested from the back on the ipsilateral side, and patient retained the limb with good cosmesis as well as good functionality. So here it's a squamous cell carcinoma of the leg on the lateral part. So here we are doing a wide excision. Here you can see a 2 centimeter margin on the entire thing. 3-dimensional clearance has to be given, and the margin is excised without contaminating. You can see where the forceps is holding the tumor. So it should not contaminate the base, and immediate reconstruction with a split thickness skin grafting has been done. So you can see the final outcome. And this is a case of carcinoma tongue where a wide excision has been done. You can see the wide excision, how wide it is. It should have a 2 centimeter margin, 3-dimensionally, and a primary closure can be done with the tongue flap itself. So this is a reconstruction in case of a small lesions. So this is a case of carcinoma maxilla, bony tumor. You can see the 3-dimensional view of the tumor here. And here is a clinical picture where total maxillectomy has been done with immediate reconstruction. So this is a case of carcinoma retromolar trigone. Retromolar trigone is considered as an inoperable disease, inoperable area. But now we have surgical techniques where even RMT tumor can be removed. Here you can see the node is infiltrating the skin in the neck near the submandibular region. So a reverse hockey stick incision has been done, and the complete removal of the tumor. You can see the upper jaw, intact upper jaw, the lower jaw has been removed. The neck dissection is completed, and you can see the carotid vessels and the IJV in the neck, and the completed neck dissection here. An immediate pectoralis major myocutaneous flap is harvested from the chest, and it is brought, and here's the defect, and it is brought into the area, and immediate reconstruction is done here. And you can see the entire tumor. You can see there is no piecemeal removal. The upper jaw tooth is there, the lower jaw tooth is there, and also the involved submandibular node is there. Everything has been removed. And in this plain X-ray, you can see how much soft tissue as well as the bony component has been removed. And here is the cosmetic outcome of the patient on the 3rd postoperative day. So there is very good cosmesis, good functionality, and also patient is having an adequate mouth opening. So this is possible because of advances in the anesthesia, drugs, and hypotensive anesthesia, and also good surgical techniques where immediate reconstruction can be done. Here you can see the buccal mucosa has been replaced by the flap harvested from the chest. So these are all some of the surgeries where we do a reconstruction, immediate reconstruction, full lip thickness, full thickness excision. This is again a composite resection for oral cancer. So this is again a composite resection. So some of the inoperable diseases can be made operable with a multimodality approach. Here is a case of a melanoma of the hard palate, and this is a case of skin tumors where near the nose we can do an immediate reconstruction with rotation flaps. And this is a skin tumor here where immediate reconstruction can be done. This is a basal cell carcinoma near the eye, a critical area where reconstruction is difficult. But here you can see a bipedal flap being used to reconstruct the defect, and with good process. You can see the critical location of the basal cell carcinoma. So these are all some of the surgical techniques which are very important. So it is a case of a total conservative parotidectomy. You can see in the picture how nicely the facial nerve has been dissected, and with the removal of the superficial as well as the deep lobe, all the branches of the facial nerve are seen. This is done for a case of a carcinoma parotid. And this is again another case of total conservative parotidectomy. Sometimes we may even have to put flaps for the parotid. So here you can see it's a malignant parotid with the skin infiltration. The skin has been removed and a flap from the chest is being used. This is another case of a recurrent parotid neoplasm where even the external ear was removed along with the tumor, primary tumor, and a very big flap from the chest was harvested and put to do an immediate reconstruction. And here again, another case of carcinoma parotid with skin involvement with immediate reconstruction. This is a case of a neck dissection for an oral pregnancy. So this is another neck dissection for a supraomohyoid neck dissection for carcinoma tongue. So in all these pictures, you may have seen there is something called reconstruction. So most of the oncological procedures have an extensive surgical resection, and immediate reconstruction is very important. So we all know about the reconstructive ladder. So why we need these things is a general practitioner or a family physician should be aware that cosmesis is also one of the important thing in the treatment of cancer. So this is a nasolabial flap for reconstruction. It's nothing but a local flap. There are other flaps like sternomastoid flap and also nasolabial flap for reconstruction of columella. And this is another innovative flap called submental flap used for buccal mucosa. The submental flap is harvested from the chin area, submental area, and can be used for buccal mucosa as well as the tongue reconstruction. So this is a flap which is brought intraorally. So these are all various techniques in the immediate reconstruction of cancer, oral cancers. So this is a case of a forehead flap for nasal reconstruction. This is a very common traditional flap. And this is a rhomboid flap used in reconstruction of facial tumors. So other distant flaps, most important is the pectoralis major myocutaneous flap, which you have seen most of the tumors, reconstruction in the oral cancers. And this is a PMMC, classical PMMC flap harvesting from the chest. And this is another PMMC flap. And also it can be used in treatment of carcinoma larynx and carcinoma pharynx, where a complete laryngophilectomy can be done and PMMC flap reconstruction can be given. And there is something called platysma flap in 3 individuals and sternomastoid flap. These are some of the innovative flaps which can be used in head and neck reconstruction. And also this is in the case of a trapezius myocutaneous flap for soft tissue sarcoma of the neck. So there is something called craniofacial resection where tumors from the skull base can come out through the nasal cavity. This is nothing but olfactory neuroblastoma. So tumor arises from the skull base and comes through the cribriform fossa and comes out through the external nasal. So here we do a combined approach where neurosurgeons operate from cranial end and they do a craniotomy and give a resection at the skull base, and the tumor is removed from the facial root. So that's called a craniofacial resection. This is nothing but a total laryngopharyngoesophagectomy with a gastric pull-up. So here the stomach is used for the reconstruction of the esophagus and the larynx. So these are all some of the various reconstruction techniques which has made even inoperable disease operable and which gives cure to the patient. So this is a microvascular flap where a distant flap is used and by microvascular anastomosis is being done. And there are even we can do reconstruction with case of mandibular defect using fibula. So this is a case of fibular free flap which is being used in case of reconstruction of the mandible. And there is something very, very important is called the oncoplasty in breast. Nowadays, the gold standard in the treatment of cancer breast is not modified radical mastectomy, but it is breast conservation surgery. So breast conservation surgery can be done with the native breast tissues, or we can use a flap. It may be a latissimus dorsi flap or a tram flap or a free flap can be used in the reconstruction of the breast. So this is a very good cosmetic outcome where a LD flap, latissimus dorsi flap, which is a pedicle flap used from the back and for the reconstruction of the ipsilateral breast. So this is another big LD flap which is used in the reconstruction. The patient will have very good cosmesis and also it has a very good outcome. And this is a radical, sometimes even for coverage of the wound, we can use such a morbid fungating tumor which would have been inoperable was removed with a radical mastectomy, and an LD flap was used to reconstruct the chest wall. So it can be used for both coverage as well as for the cosmesis. So some of the tumors like these bony tumors like sacral tumor, which are very much critical and inoperable sometimes, that can also be removed with the procedures called sacrectomy. It's a case of transhiatal esophagectomy where we can, even in a peripheral setting, we can do a transhiatal esophagectomy in case of carcinoma esophagus, where without opening the chest wall, you can see in the right upper picture, a hand is in the abdomen and another hand is in the neck. So without opening the chest, we can do a total esophagectomy and replace it with the stomach tube, and that is nothing but called as a gastric conduit. So in this, you can see the staplers being used in the reconstruction of the stomach into a esophageal gastric conduit. So this is another surgery called a nephron sparing surgery. Nowadays, total removal of the kidney is not done in all cases of carcinoma kidney. So if the tumor is in a polar area, superior pole or inferior pole, and if it is amenable for a nephron sparing surgery, a partial nephrectomy can be done. So this is a case of a partial nephrectomy, only the upper pole was left. So coming to bone tumors, so this is a case of a proximal humerus tumor in a 2-year-old girl. It was diagnosed as osteosarcoma Patient was started on neoadjuvant chemotherapy, and you can see the tumor in PET scan. And it's a non-metastatic disease. Patient had very good regression after the chemotherapy, and we did a limb salvage procedure in a 2-year-old girl. So here it's a combined anterior and posterior approach. We do 3 osteotomies: scapular osteotomy, triceps dissection, and humeral osteotomy, and removal of the entire tumor. Here you can see the tumor from the humerus, and you can see the entire upper limb is completely disconnected from the body. Only the neurovascular structures is intact. And after that, we reconstructed with bone prosthesis. The prosthesis was manufactured on table using bone cement. So this is the processes which was used, and a mesh was used in the reconstruction of the bone, and over that a myoplasty was done using a mesh, micro mesh. So these are all some of the innovative techniques which are used in the reconstruction. So oncology has gone through a lot of stages, where from very morbid aggressive procedures, it has come to a conservative procedures without compromising the quality and cure of cancer. So finally, in this case, you can see the year-old baby. So patient was able to move the limb. The upper limb was movable, and is one of the smallest or the youngest baby for which we have done a bony reconstruction. So this is a tagged specimen. You can see how a specimen has to be tagged: the superior margin, inferior margin, medial and lateral margins, so that it will be useful for the pathologist to assess the margin status of the tumor. So this is a baby here with the good movement of the upper limb. And the final HPR came as osteosarcoma, and adjuvant treatment was given. So these are all some of the pictures I thought we'll be sharing instead of giving technical details about surgery. So some of the myths about cancer is food fads. They always think that some of the foods will protect us from cancer. So whenever the patient is diagnosed with cancer, they will suddenly switch over to a nutritious or a diet which has less of a lot of nutrients. So sometimes a non-vegetarian person may switch over to a vegetarian. So these are all some of the food fads which are a myth about cancer management. And also another thing is they wanted to take rest after treatment. So, but for cancer treatment, it is early mobilization which gives a better cure. So always I ask the patient from the first post-operative day itself, they have to mobilize themselves. And also people think that cancer recurrence happens in all patients of cancer, but it is not so. But there are options called second cancers. A patient who has developed a cancer in one part of the body can develop cancer in another part of the body. And also now a new thing is called as a fasting or autophagy. So intermittent fasting helps us in preventing cancer recurrence and also prevents in the first instance of cancer. And similarly, exercise, a regular exercise also has a very good effect in preventing cancer. So these are all some of the things about cancer. And to summarize the topic, cancer is curable in most of the instances, and early diagnosis and prompt initiation of appropriate management is critical in the treatment of cancer. And the roles of patient, relative, physician, and surgeon is very, very important. And surgery is one of the most important treatment modality which predicts survival, and multimodality treatment and follow-up is mandatory in management of all cancers. So with this, I take the opportunity to conclude my presentation because I wanted to stick to time with just 20 minutes. So thank you all for the opportunity, and we can have a doubt session now or after the completion of all the 3 speakers. Thank you for the opportunity. Thank you, sir. Sir, Nagaraj sir, I have come to the end of my presentation.
Yeah, but I'm muted here. I don't know how to speak. Hello?
Yes, sir, you can. Yes,
Yeah,
sir, you're audible, sir.
All right. Okay. Thank you so much, Dr. Mohammed. And it was a very elaborate talk. Right from the beginning, how the relevance of early diagnosis and all of those fancy, very impressive radical surgical procedures, but we should ensure that we don't reach there. And therein comes the role of a family physician, not only to manage this cancer, but then every time they go to see them and seek their help, that's the time when we can also counsel them of the relevance of early diagnosis. We don't have organized programs, but even then, the family physicians can fill in that and make certain that we don't really end up with all those ghastly looking fungating tumors. And that's still the reality in our country. And thank you so much for also emphasizing about the myths and also emphasizing not to do the doctor shopping, because time interval, it has been shown empirically that if the interval increases between the diagnosis and the ultimate treatment, then the outcomes are very poor. Wonderful talk, and I'm sure all of us have been benefited by that. Thank you so much. And so we move on to the next one by Dr. Vijay Patil. And he's going to talk about, he's a medical oncologist. He's from Hinduja Hospital. Has also worked, he's now has also worked in Tata Memorial Hospital. Is going to talk on every cancer cell has its own signature.
Yeah,
And we generally say that it's the tumor biology which determines the outcome. Yes, indeed, it does. And Dr. Vijay Patil is going to talk about it. And there we have his very impressive biodata on the screen. So, Dr. Patil, it's all yours.
Thank you, sir. If you can just allow me to share the screen. So, is the screen visible, sir?
Yes.
Yeah, okay. So, the topic which was given was that every cancer has its own signature. And whenever we talk about cancer cell signature, we actually are talking about genomics of the cancer. And as Dr. Nagaraj rightly pointed out, about the biology of the cancer. And I was thinking about making this presentation about showing all types of cancer. Then I decided that I'll take the situation of only one cancer to make a point how development of cancer genomics, development of appropriate target therapies has changed the face of the cancer. And the cancer which I selected is non-small cell lung cancer. What I'm showing you is most of the time, non-small cell lung cancers will be seen in advanced stage in a country. So they will be in stage 4. This is a very classic article, came in 2002 in New England Journal of Medicine, in which they showed that whichever type of chemotherapy you give this patient, the outcomes are at the most dismal. The average survival in stage 4 lung cancer is around 8 months. And by 1 year, around 40% patients are alive. There goes always with this a survey which was done in Canada. And this survey was done on thoracic medical oncologists. And they were asked a single pointer question. If you develop stage 4 lung cancer, would you take palliative chemotherapy? The findings were interesting. Only 5% of Canadian medical oncologists said that if they developed stage 4 lung cancer, they would take chemotherapy. And with this, we can understand what was the dismal outcome of this disease with chemotherapy. And this was seen even till recently, a paper of a randomized study from Tata Memorial Hospital, where I used to work previously. And you could see that the average survival in this patient is around 8 months. Very limited average survival, around 7 months. Very limited progress was being made until we started doing molecular profiling of the tumor. Now, why do we do when we do molecular profile? You will be hearing this word, and this word will be becoming more and more common. We are actually looking for mutations. We are not looking for any mutations. Mutations are of 2 types. They can be driver or they can be passenger. Driver mutations, as the name suggests, they drive the tumor. Passenger mutations, as the name suggests, are there and they don't drive the tumor. So you actually are looking among all those mutations which the cancer has for driver mutations. And if there are driver mutations, then you can develop targeted therapies for these driver mutations. And the next 15 minutes, I'm going to show you the success rates which this yield. These are interesting data. This is from India. And what it showed is in 23% of patients, with this figure can differ between 20 to 30, depending on which part of India you are. there is a mutation called EGFR mutation, which is seen in non-small cell lung cancer. And this is specifically seen more likely in adenocarcinoma. As respect to, only 10 to 15% of Western world has this mutations. Now, does this impact therapy? And let's look at this study. And this was again done at Tata, and I was the principal investigator for this study. In patients who had EGFR mutation positive disease, we give them a tablet to like a BP tablet, which can be taken at home. This tablet is a targeted therapy which blocks EGFR. We gave them the best chemotherapy at that time. It was not a surprise that the tablet was a clear winner, and it improved the outcomes in these patients. The side effects were less. The quality of life was also improved. And this was not in one study. There were nearly 7 to 8 studies which have been done across the world, in which all across we had seen that, okay, with tablets, we could improve survival. How much we could improve? Remember, the average survival I told you figure was 8 months. Now with this tablet itself, from 20 to 30 months, that was the range of survival which we could improve. Many of you would tell, okay, this may not be that great, Dr. Patil. Yes, this may not be that great. But when we used to give chemotherapy for 6 to 8 months of average survival, with respect to that, it becoming 20 to 30 months was quite a big achievement at that time in medical oncology. And I'll show you how further we have increased this. In fact, we also developed some targets in Tata in which we identified a gene called FGFR3, exclusively seen in lung cancers in Indian population, and it is also drug sensitive. Just to show you how our molecular chart differs from that of a Western chart. You could see that nearly 30% of our patients have EGFR. FGFR3 is the next most common, which is not even seen in Caucasian population. KRAS, which is very common there, is seen in 10 to 15% of our patients. Now this graph, where it is unknown mutation, this was 2017. In 2023, this lies around only at 25 to 30%. Most of the patients will find some or the other mutations. And these mutations can also be found in squamous cell carcinomas. We can have mutations which can be in something like HER2 mutations, which you would have heard about HER2 amplification, which is seen in breast cancer. Now, why is this important? The importance is when I used to give chemotherapy, the chances that the disease would shrunk used to be only 20 to 30%. As opposed to that, when I gave this molecular targeted therapies, the chances that the disease would shrunk is as high as 85 to 63%, which means there's a good fast symptom relief for the patients. And you could see in this chart how nicely the tumor disappears when you give appropriate targeted therapies. Now, does targeted therapies always benefit adeno also or squamous also? Yes, it benefits across all age, all genders. So if you have a mutation and if you give an appropriate targeted therapy, it benefits. The problem is, up till now we were talking about EGFR mutation. Now, EGFR mutation is like India. India has multiple states, it has multiple districts, it has multiple talukas. Same way, EGFR is a big gene. It has multiple exons, multiple introns. On the multiple exons, you have multiple codons, and all these multiple codons, you can get different types of combinations of mutations which can be there. And this is a list of the uncommon mutations which are seen commonly in India, in EGFR itself. Now, each of this has different sensitivity to targeted therapies. Different drugs have different impact. So it's not only important that you know that which mutation it is, it's also important to know which type of mutation it is. Now, why I'm explaining this in so much details? Today, most lung medical oncologists would ask the patient after having a biopsy, and if he's not overly symptomatic, to wait for this mutation analysis to come. Because if it is mutation positive, you don't have to give chemotherapy to the patient. Most of the times, you can get away by giving oral therapies itself, which have better response rates, better outcomes, less side effects. Now, the mutation report takes anywhere between 14 to 20 days to come. And this is where the general practitioner, who is a family physician, comes in to help. But he needs to counsel the patient that, okay, in lung cancer, you need to get those mutation reports, because these mutation reports can change the way you get treated. Now, I told you the first generation drug, Geftinib, gave us numbers of around average survival between 20 to 30 months. Have we improved it? And that study came in 2010 and 2013. Yes. Now we have developed second generation inhibitors and third generation inhibitors. And I'll show you the study of a third generation inhibitor, which was study done across the globe, in which a third generation inhibitor was compared against the first generation inhibitor. And now what you see is, where average survival used to be for patient of 8 months, at the end of 2 years, nearly 80% of the patients are surviving. At the end of 5 years, in this study, nearly 60% patients are surviving. So you can now understand, we went from an average survival of 6 to 8 months to 5-year lifespan of 60 to 70% in specifically EGFR mutated tumors when you treat with them with a drug called osimertinib. Now, fourth generation TKIs are coming, and we are eagerly awaiting the reports of this fourth generation TKIs. The way it is going, it seems that very soon this might get converted into a therapy which may be like blood pressure. And that is the aim which most of the medical oncologists who are working in the field of lung cancer are trying to obtain. The problem is osimertinib is costly. The original drug by AstraZeneca is very costly. And that's the reason why this research was led by my colleague, Dr. Narona, in which we tried to combine chemotherapy with a first generation TKI and tried to see whether we could improve on the results. Yes, you see that if you give a combination of chemo plus a TKI, then again, you can get the benefit which is similar to a third generation agent. And why is this important? This is important because the cost of osimertinib is 1.6 lakhs per month. But the cost of TKI plus chemotherapy is only 3,000 per month. So in a resource constrained setting like India, if you cannot afford osimertinib, giving a first generation TKI with a chemotherapy and serve you the same, nearly the same purpose with much lower cost. And we need to have researchers like this, which focused on the socio-economic status of India also. Now, the question comes, how do you do mutation analysis? You need to take biopsy. From where do you take biopsy? You can take the biopsy from the tumor. It can be from the lung, it can be from the bone, it can be from any other part where there's a mets. Now we have started developing liquid biopsy. What does liquid biopsy mean? We take the blood sample of the patient. From the blood sample, we extract the DNA. And from that extracted DNA, we can extract the DNA of the tumor and look at what mutations the tumor has. Is it developed in India? Yes, I was the principal investigator of this study and we developed this in India. And the concordance, which means is actually around 85 to 90%, which means what you can get from tissue, you can also get from liquid biopsy. In fact, ideally, you need to send both the biopsy from the tissue and biopsy from the liquid, because the liquid can miss around 10 to 12% of the time, but the solid also, that is tumor biopsy, can also miss in around 18% of the time. So the best combination is actually doing the biopsy both from the tissue and the liquid. Let's shift gears to show you other type of lung cancer, which is ALK positive. Now, here also there's an oral targeted therapy, and this is first generation. And you could see these are the results from Tata, where you could see 3-year survival is around 50%, 5-year survival is around 33%. Now, if you look at this with respect to the 6-year survival which came in the study, and that will be 72 months, it's around 60%. So you have shifted from an average survival of 6 to 8 months in ALK positive tumors to a 5 to 6 year survival of around 60%. Now, this is just the start. If you look for patients who had second generation and third generation agents, the shift has been even more, and today, with the best third generation agent, the 5-year lifespan of this patient is around 70 to 80%. And this is not the story just for ALK and EGFR. This is the story even for ROS1 agent. You could see when you have ROS1 tumors, and if you give them the therapies, and these are results again from Tata Memorial Hospital, you see that 30-month survival is around 90%. ROS1 is very exclusive sensitive to appropriate targeted therapies. Same way, if you have BRAF tumor, a BRAF inhibitor can give you response rates of as high as in first line setting of 40%, in second line setting of 38 to 35%. An appropriate BRAF inhibitor, which like dabrafenib can shrink the tumor in 70% of the cases. This is again the data which shows that around 5-year survival of around 30 to 40% can be achieved in a BRAF mutation positive case with the appropriate targeted therapies. Do we have other targets? There are multiple targets. So I'm now talking about a target called NTRK. Now in NTRK, you see that when you give therapies, nearly 80% patient response, and you could see that those who respond, they just continue to do well. Even if they have brain mets, they continue to do well. The average survival in the situation is around 40 months. 5-year survival is around 40 to 50%. And you could see here, this is for another mutation called MET mutation. Except one patient, all patients had some kind of decrease in the tumor. What I'm trying to stress you is, today there are multiple type of mutations in it. And each of these mutations has a different therapy, and most of these therapies are successful. Now, in general, when the patient is to a poor performance status, that is, a wheelchair patient or a patient who is on bedbound, we never used to treat these patients. But with this targeted therapies, if they are targeted therapy positive, like EGF or ALK positive, then you can treat these patients and they benefit with this treatment. Last but not least, if they don't have any targetable mutations, you go ahead and look for immunotherapy markers. Immunotherapy is the latest type of therapies in lung cancer. This is specifically for patients who are mutation negative. Mutation positive patient always need to be treated with the mutation inhibitor, that is targeted therapy. Mutation negative, you can treat with immunotherapy drugs, and you could see that if it is mutation negative with immunotherapy drugs, the 5-year lifespan around 32% can be achieved. Now you can understand that from 6 to 8 months to 5-year survival of 30%, going up to 70-80% is something of a remarkable things which we have achieved. And immunotherapy, even in Indian data, has shown wonderful survivals in this patient, where you could see the patient who respond, nearly the 3-year survival is in the range of around 60%. And patients who are poor performance status, who are wheelchair bound, they also benefit with immunotherapy. So what has changed in last decade in lung cancer? Mutation analysis, immunotherapy markers has changed. Today, we give chemotherapy only and is restricted to only less than 17% of the patients. If the patient has the resources, patient will get targeted therapies or immunotherapies. And immunotherapy is costly, and hence we have developed low-dose immunotherapy protocols. This has completely been done in head and neck cancer. For lung cancer, it's a work in process, which brings down the cost of these drugs for the schedule from 64 lakhs to around 4 lakhs per year. And with that, I'll take any questions which are there. What I wanted to make is, oncology with the help of mutation analysis is changing rapidly. We have got changes in which we have shifted from chemotherapy to targeted therapies with success rate of 5-year survival of around 60 to 70%. If there's no mutations, then we have changed it to immunotherapy drugs with a success rate of around 30 to 40% in this situation. But the most important thing is, even in this situation, you need to have a multidisciplinary approach. Even in stage 4 lung cancer, there's a protocol called Gomez protocol, in which if your patient does very well with immunotherapy or with targeted therapy, they need to be consolidated with radiation or an SBRT, which needs to be given in this patients. With that, I thank you all for patient hearing. I thank the organizer, Nagaraj sir, for this opportunity. And if there are any questions, I'm happy to take them.
Dr. Patil, thank you so much. The story of hope. And I think the best example is the actor Sanjay Dutt, who is said to have had a very extensive lung cancer. And when I started my practice, in fact, if you had lung cancer, you did nothing. That prompted because put together, the scenario of lung cancer has changed tremendously, and you so succinctly elucidated the whole paradigm shift and the benefits that has that we have. She's a radiation oncologist and she's from CMC Vellore. She did her MD from CMC Vellore, and now she's also the professor of radiation oncology in CMC Vellore, one of the most premier institutions of the country. Radiation oncology, some aspects of medical oncology, is changing rapidly. Technology has made a lot of difference in terms of escalating the dose and reducing the side effects. And we have now put on accelerators in India, 2 of them, and another 3 or 4 of them are coming. We also have MR-based linear accelerators, and so many exciting things are happening in the last 1 decade. So Dr. Pamela is going to introduce radiation oncology and the recent advances. And that's a ray of hope, yes. I mean, in fact, the previous Dr. Patil's this lecture was also about hope, because there has been a significant change when it comes to certain types of lung cancer, even though they were advanced. Yeah, here we have Dr. Pamela.
Thank you, Dr. Nagarajan, for that introduction. I take this opportunity to thank Dr. Ramesh Babu, Dean, IMA CGP Headquarters, and Dr. Anburajan, Honorary Secretary, IMA CGP Headquarters, for giving me this opportunity to present in front of you today. And the topic which is allotted to me for today is the ray of hope, newer advances in radiation techniques. So it is indeed an odyssey to precision. Radiation has moved from 2D techniques to precision. So I am basically a product of Tirunelveli Medical College, where I did my MBBS. I belong to the batch 1984. After that, I did my MD Radiation Oncology from Christian Medical College and Hospital, Ludhiana. I bring greetings from CMC Ludhiana, a glorious legacy of treatment, research, and education since 1894. Our founder is Dame Edith Mary Brown, and our vision is my work is for a king. So with this, I will take you all in a journey today with the introduction to radiation oncology and a brief introduction to interaction of radiation with matter, therapeutic ratio, why there is a need for precision, and the different precision radiation techniques, radiation treatment machines, and the future perspectives. So there is change in everything. When you take about communication, we have changed from how we communicated in those days to now like more advanced ways of communication. So even if you take surgery, we have moved from open surgery to laparoscopic surgery and robotic surgeries. There is a change in every modality of cancer treatment, including chemotherapy. We heard from the previous speaker how we have gone up to immunotherapy. Radio diagnosis, our sister department, we have progressed from 2D imaging to ultrasound and to 3-dimensional imaging to MRI and now to functional imaging. So radiation oncology is a technologically driven, continuously evolving oncology modality that is moving towards precision. It is a branch of science that utilizes the therapeutic use of ionizing radiation in the management of predominantly malignant tumors. So when I finished my MBBS, I had no idea what all these radiation therapy is about. So I just have one slide just to tell you what really happens when radiation enters our body. So radiation can have its action in our body in 2 ways, a direct action and an indirect action. So in the direct action, you can see that the target for us when we treat a patient with radiation is the DNA. So in the direct action, radiation, which is a photon, which is a packet of energy, is directly hits the DNA helix and causes breakage of bonds there, causing DNA damage. In the indirect action, we all know that we are made up of more than 80% water. So we have so many water molecules, which are hydrogen and oxygen bound together. So the radiation will react with these water molecules and then giving rise to free radicals, which can diffuse through the medium and cause damage to the DNA helix. So this is the indirect action of radiation. I just wanted to know that you may wonder what happens when radiation goes into our body, and this will mainly target the proliferating cells. So another important thing in is the therapeutic ratio. So the therapeutic ratio denotes the relationship between the probability of tumor control and the likelihood of normal tissue damages. And improved therapeutic ratio, that is when you have the gap, between these two graphs widen, then we can, it represents a trade-off, favorable trade-off between tumor control and toxicity. The wider the gap it is, we will be able to escalate the dose to the tumor without compromising the dose to the causing toxicity to the normal tissues. So the principle of radiation oncology is to deliver maximum dose to the tumor with minimum dose to the surrounding normal tissue structures, thus achieving a higher cure rate with acceptable morbidity. So we can see here that this is the nasal cavity. We want to give maximum dose to this tumor while protecting the orbital structures. So we need precision here. That is the key to conformal radiation therapy. So we can see what are the various radiation therapy techniques we have had. We've had conventional, we have started from conventional to 3D conformal radiotherapy to IMRT, that is intensity modulated radiation therapy, to image guided radiotherapy, to stereotactic radiosurgery and stereotactic body radiation therapy. So starting with conventional radiotherapy technique, which we were using before the 1990s, is that if you want to treat a pelvic tumor, for example, cervix, this would be the field which we would be giving. And we can see not only the tumor bearing area, but the normal tissues also get radiation. And we know that anteriorly we have the bladder and posteriorly we have the rectum. So they would be receiving doses of radiation. And this is exactly what showing the area which will receive radiation. So the limitations are that in conventional there's lack of three-dimensional visualization of the tumor. The irradiation of large volumes of normal tissues happen, and there are lack of tools for efficient planning and delivery of radiation, resulting in us giving large safety margins and thereby compromising the tumor dose because we will be radiating the normal structures also. So what we were doing in conventional radiation therapy is we are doing a two-dimensional planning of a three-dimensional tumor. So there's an obstacle which was realized, and precision in radiation oncology with more sophisticated treatment delivery techniques was the answer. So for all these, we cannot stand alone and take the credit for all these precision methods. We go hand in hand with our sister department, that is radio diagnosis. As you can see, there's various imaging modalities are used right from the diagnosis, staging, the treatment simulation, the treatment planning, treatment localization as in image guided radiation therapy, treatment delivery, and response assessment. So going to three-dimensional conformal radiotherapy, you all would have heard something like 3D CRT. So what is it? Here, what we do is we use this multi-leaf collimators. So you can see that in the red square area would have been the region we would have treated if we were doing conventional radiation therapy. So with the use of this multi-leaf collimator, we are almost able to conform almost to the shape of the tumor. We could get different shaped fields to treat the tumor tissue. So this is an example when we treat with 3D conformal radiotherapy of the hypopharyngeal region, we can see that we are able to almost conform to the shape of the tumor while protecting the normal tissues. But in contrast, if only we had treated this with conventional radiation therapy, this would be the area which would be receiving radiation. And we can see that the spinal cord is also involved in the treatment field. And so the limitations are there for 3D conformal radiotherapy because there is considerable doses are still received by normal tissues, especially when the tumor is engulfing the normal tissue. So the second, the one is the intensity modulated radiation therapy, which is an advanced form of 3D conformal radiation therapy, which had used multi-leaf collimator. But in the intensity modulated radiation therapy, the intensity of the radiation beam would vary across the beam with the use of this dynamic multi-leaf collimators, which can move in and out of the irradiated area, thereby causing a varied intensity along the area treated, so that we would be able to protect the normal tissues even if they are engulfing the tumor. So this is an example of 3D CRT plan on your right side, where we are treating a spinal cord tumor in the vertebral body and the posterior elements. We are using two oblique fields, a right posterior oblique and a left posterior oblique. And then we can see how we are able to see the treatment plan, that it is involving there is dose to the spinal cord also. But on the other hand, if you see the IMRT plan, which is on your right side, we can see that how there are obviously the number of fields are more, and there is intensity modulation in each of the beamlets of a particular beam, and we are able to spare the spine from the radiation. So the oncological outcomes of intensity modulated radiation therapy as compared to conformal radiotherapy for nasopharyngeal cancer, this is the results of a meta-analysis which showed that that it favored more towards the IMRT technique as compared to the conformal radiotherapy with regards to disease-free survival, overall survival, and loco-regional control. This is a prospective randomized trial comparing 3D CRT and intensity modulated radiation therapy. And the authors, this is from Tata Memorial, authors concluded that IMRT provides a clinically meaningful and sustained reduction in the incidence of moderate to severe xerostomia and subcutaneous fibrosis compared to 3D CRT, while compromising without compromising disease-related outcomes in long-term survivors of non-nasopharyngeal head and neck squamous cell carcinoma. We all know that dose escalation, if you escalate the dose to the tumor, it will definitely result in improved survival. So you can see here with higher doses, how we attain the survival benefit, but at the cost of what? At the cost of grade 2 plus GI toxicity. So this is a paper showing the role of intensity modulated radiotherapy in prostate cancer. So here we could escalate the dose to the prostate to higher dose levels with improved toxicity profile. So now in a human body, everything is dynamic. There is movement everywhere. So how do we do that? Like neither the tumors nor the normal structures are stationary. They move in between and during treatments. So this is an obstacle for us even when we do precision radiotherapy. So how do we manage that? This is just showing an example of a tumor of the lung, and you can see how it is moving up and down during respiration. And this movement is different in different lobes of the lung. Like for example, in the upper lobe of the lung, the movement is in the range of 0 to 0.5 centimeters, but in the lower lobe, we can see the range of movement it's from 1.5 to 4 centimeters. So what is the problem of moving tumors? In simple words, the problem with moving tumors is because the tumor is moving, we have to give margins. So by giving margins to the tumor which is moving, we increase the irradiator volume. For example, for this tumor, which is 1 centimeter, by giving margins, we are increasing the irradiator volume, the margin of 3 centimeters movement. So that is like exposing the normal tissues to more radiation. So this is a problem. There should be a solution. The solution is image-guided radiation therapy. So I will quickly take you through the principles of image-guided radiation therapy. It is the capability to image a patient immediately before or even during the actual execution of treatment. It is to confirm that the radiation is being given exactly as intended. So we can see that the imaging is done while the treatment is going on, and we are able to see where exactly the radiation is being delivered. Now, are there any other ways to minimize the uncertainties of tumor movement during respiration? Yes. Treat the moving. One is the respiratory gating. So you can see on the left side, that we can see that the tumor which is there in the blue contour is within one area. So the beam will be on only when the tumor comes back into its initial position. Only then the beam will be on and it will be treated. When the tumor moves out of this area, then the beam will be off. So this can be taken care of by getting the respiratory cycle of the individual patient and aligning the beam on and off position in accordance with that. This is called respiratory gating. The other method is tumor tracking. Here, this beam is always on, and then we are just chasing the tumor, and we are tracking the tumor, and then we are irradiating the tumor. This is tumor tracking. It lessens the irradiated area by 33%. So in a nutshell, if I need to talk about IGRT, you can see that motion inclusive is that we are using a larger area, which will be included in the radiation field. The middle panel shows you how we can do gated radiotherapy, where the beam is on and off positions. And on the right side is the tracking. So image-guided radiotherapy is designed to ensure accurate and precise targeting. So there are many evidences to prove that IGRT helps us to reduce the margin around the tumor and thereby limiting the normal tissue toxicities. These are some more studies to say that how it improves by reducing the margins and how we can reduce the normal tissue toxicities and improve the quality of life. So we talked about 3D CRT, IMRT, and IGRT. So all these while we are all doing and talking about treatment and planning in two diagonal this thing. So coming to stereotaxy, that is, we are here in stereotaxy, we are defining the target point in space by 3 distances in relation to 3 orthogonal planes, which is X and Y, which usually we do, and along with an additional Z orthogonal plane. So this is just to give an example how we can localize the tumor using these orthogonal planes, and the distance is measured from the surface and how we can treat. So we have a technique which is called the stereotactic radiosurgery. It was developed by Lars Lexell in 1949. It is used as a non-invasive alternative option to open neurosurgical approaches. And it helps in precise delivery of high-dose radiation to an intracranial target in a single session. That is why the name stereotactic radiosurgery. It's like performing a surgery by means of radiation. So we have, what are the equipments we use? We have gamma knife, which utilizes 201 cobalt sources, which is a radioactive isotope, which can be focused to treat a small area of tumor. And we have the linear accelerator with X-knife facilities, where again, we can use it for treating small tumors with radiosurgery. So what are the indications of stereotactic radiosurgery? Arteriovenous malformations, meningioma, pituitary adenoma, aquestic neuroma, trigeminal neuralgia, brain metastasis, and skull-based tumors. Now, coming to the next technique that is called, you would have heard SBRT many a times. It is stereotactic body radiotherapy. It is the delivery of high dose of radiation to an extracranial target within the body using very few fractions, that is less than 5 fractions of radiation. That is, the dose per fraction is high, and it is an ablative dose. The indications would be, like some of the indications would be inoperable lung cancer, stage 1, medically inoperable hepatocellular carcinoma, locally advanced pancreatic cancer, recurrent bone metastasis, early stage prostate cancer. So you can see that how accurately we can hit the right spot with stereotactic body radiotherapy in lesser number of fractions and over a shorter period of time. So the NCCN recommendations for medically inoperable non-small cell lung cancer is definitely radiotherapy with stereotactic body radiotherapy. But when you compare the treatment with conventional radiation therapy, the 3-year survival was approximately 30%. But when you use SBRT, we can see that the three-year survival ranges somewhere from 80% to 90%. So clinical outcomes are comparable to surgical resection. So we have so far spoken about all these techniques. Now, where do we go? So what are the radiation therapy equipments which are used? Are mainly linear accelerator, helical tomotherapy, cyberknife. And we should not forget that many patients were benefited with the advent of cobalt-60 in the last century. So just one slide on cobalt-60. Cobalt-60 revolutionized cancer treatment, and it houses a radioactive cobalt-60 in its head. And the disadvantage is that the half-life of cobalt-60 is about 5 years, and so it needs source replacement. And nowadays there have been advances in cobalt-60 machine also, and some sort of 3D conventional radiotherapy techniques can also be done with cobalt-60. And there are issues with radiation protection with cobalt-60 because of the radioactive isotope. Now comes the linear accelerator. This is the machine which brought the transition to precision radiation. See, the advantages are because there is no active source inside, there is least radiation hazard. It is for all techniques, and it has a dual mode, which can be an electron beam or a photon beam mode. So electron beam can be used for superficial tumors, and the photon mode for treating deep-seated tumors. So, and it also has the skin sparing effect of mega voltage radiations. So what we have to take home is that with linear accelerator, we can treat superficial tumors also with the electron beam, and with the photon beam, we can treat deep-seated tumors also. So these are the various linear accelerators from Electa and Varian, which are available. And talking about helical tomotherapy. Now, helical tomotherapy is an innovative radiation therapy machine. It combines a linear accelerator and a helical CT scanner. It is treatment is done slice by slice, and there is a daily low dose CT imaging. So the advantage of helical tomotherapy is the ability to handle a long treatment lengths, and it increases the precision of treatment. Now, quickly coming over to CyberKnife, it is the cutting edge technology. As you can see from the image, how well we have progressed with technology. And it is nothing but a small miniature linear accelerator, which is mounted on a robo. The tumor position is verified, and robo adjusts the linac in different angles. This robotic arm has 6 degrees of freedom of movement, and it can take more than 100 nodal positions. For each position, it can have more than 1,000 different positions. And it accommodates for all forms of patient, tumor, and related motion, even while the treatment is being delivered, because there is image guidance also. And there is no need for a rigid frame which needs to be fixed to the head. There is no need for that. So CyberKnife has the advantage of fast planning, fast delivery, accurate sub-millimeter stereotactic treatments, and also motion synchronization. So the clinical applications of CyberKnife would be previously irradiated lesions, tumors of the lung, liver, and spine, lesions adjacent to radiosensitive structures, and limited brain metastasis. Now all that we have talked about is about the teletherapy machines. Like now we talk about brachytherapy. Teletherapy is, tele means distance. The source of radiation is away from the body. It is at a distance from the body. Brachytherapy, brachy means short distance. Here, the sealed radioactive sources are implanted in and around the tumor. So we started with two-dimensional point A based brachytherapy in carcinoma, cervix, and then there was limited accessibility to imaging, and dose calculation facilities were limited. So we have now moved on to 3D image-guided brachytherapy with the widespread availability of imaging technique and the introduction of MRI-compatible applicators. So with MRI, we are able to appreciate a better soft tissue contrast. So image-guided brachytherapy has gained widespread acceptance with promising outcomes. So these are the various indications for brachytherapy. Just to introduce you to the different types: intracavity, when it is introduced into cavities, when the radioisotopes are introduced into cavities, like in carcinoma cervix and endometrium. Intraluminal is into lumens, like CA esophagus and bronchus, when there is a luminal compromise, mainly in a palliative setting. And mold brachytherapy for skin, lip, and extremities, and interstitial brachytherapy in sites like in tongue, breast, prostate, cervix, and intraoperatively, like the intraoperative bed can be treated in soft tissue sarcomas. Now, what is the future? We are not stopping here. There is more to come. That is the proton beam therapy, the flash radiotherapy, the MR-Linac, the artificial intelligence for contouring, radiomics, and radiogenomics. So proton beam radiotherapy, as you can see, I just wanted to tell you the difference between a photon and a proton. The photon is a packet of energy, which is the form of X-rays and all that, and which the energy contained in each packet is so high that they cause the damage to the DNA. But proton is the particulate radiation therapy. So in radiation therapy, when we talk about it, we talk about electromagnetic radiations and particulate radiation. So the photon is the packet of energy which we get in X-rays in linear accelerator, and proton is the particulate radiotherapy. So we can see the red and the yellow regions. The red region is the high dose region and yellow is the low dose region. So when you treat a brain metastasis with photon, we can see that it enters through the anterior part of the skull, and that there's dose distribution till the posterior part when they come out. But in the proton beam, we can see that the high dose region is confined to the tumor. That is because we have something called a Bragg peak, which is when the proton, when it enters to the body, it does not deposit its energy. It deposits all its energy when it comes to a halt. And if that area is made to match with the area of the tumor, the maximum dose is given to the tumor. And so the advantage is that there is no exit dose when you treat with proton beam therapy. So the indications for proton beam therapy are tumors which are close to spinal cord or critical parts of the body, unresectable sarcomas, pediatric tumors, and in cases where we need re-radiation. Coming to flash radiotherapy is like in conventional radiotherapy, we call something called dose rate, which is less than 0.1 gray per second. We need to hit the tumor hard. So we give a very high dose rate of more than 40 gray per second. So the tumor is hit very hard, and that is flash radiotherapy. And it is very less time, and we have to be very careful. It is not yet used in human beings here now, but we have to be very careful in selecting what patients we should be treating with flash radiotherapy. MR-Linac is a hybrid linear accelerator in which the linear accelerator and with an MRI scanner that can generate daily images of the patient during treatment. So this is what we see, that we can see that it is a sort of adaptive radiotherapy where we would be able to see the MR images and the area being treated. And if there is any motion, like for example, if we are treating pelvic tumors, there could be changes because of the bladder filling or rectal filling or a gas which could pass through the rectum. So MR-Linac, we can control all these by adapting to the changes which happen due to motion. So I have to say that whatever advances we have not traveled alone. We always had our sister department with us. With the advances in imaging, that has really helped us to go towards precision. So what is the future of precision radiation oncology and functional imaging? I just wanted to point out that tumor is not homogeneous. Tumor has a lot of heterozygosity where some areas could be hypoxic. So when we treat the tumor with radiation, not knowing which are the hypoxic areas, those areas can give rise to recurrence at a later date. So this functional imaging can just pick up these hypoxic areas, and we would be able to treat those areas with more dose without increasing the dose to the normal structures. We spoke about SBRT and proton beam therapy. We spoke about MR-Linac, and molecular radiotherapy is coming in a big way. And the combination of concurrent immunotherapy and radiation oncology, immuno-oncology is also coming in a big way. How does artificial intelligence and adaptive planning help us? Because this is auto-contouring, machine learning, all these things will help us to be very, very, very accurate about tumor delineation. Because if we are not accurate in delineation, all these precision techniques will go waste. So the journey goes on. So in future, we would be seeing incorporation of new imaging biomarkers into multiple levels of treatment, integration of artificial intelligence into radiotherapy planning pathway, combination of precision radiotherapy with novel immune modulators, emergence of immunoradio-oncology, and development of new imaging biomarkers. I have to say that we have advanced so well, but I need to caution all of you about something. We are getting into precision, we have advanced, but at the same time, we should be careful that the treatment techniques don't get commercialized. So it is amazing as to how far we have come. It is this progress which have made this therapy one of the strongest pillars of cancer treatment, but we should take every care that we do treatment ethically for the benefit of the patient. Groundwork for a successful journey is to know how to choose the right tools and the techniques. Thank you for your patient hearing. Thank you.
Thank you, Dr. Pamela. This was a wonderful, a long journey, journey of hope, journey of transformation, journey of technological innovations. And at the end of it, as you rightly said, it has improved therapeutic ratio, which has helped us to escalate the dose without causing additional toxicity or even reducing the toxicity to normal tissue. I'm very happy that you also made a concluding remark wherein with the plethora of technology, and it becomes very difficult for patients to choose which is the best. And you also did talk about commercialization and the cost and so on and so forth. So, sometimes patients come and say, I want the most expensive or the most latest. And these are the kind of things which we need to deal with. And herein comes the role of a family physician. And I would urge all the family physicians, when they come to you and they talk about these techniques, please do have a very open discussion with a radiation oncologist, because to understand the relevance of that particular technique and the technology in the given context. Well, we have now, when I joined radiation oncology way back in 1980, we were still struggling in the sense that people thought that it's only for the dying or it's only about palliation. From there to now, it has been a wonderful, wonderful progress and transformation. Now, the primary radiotherapy can be there for vocal cord, cervical cancer, prostate, lung cancer. They are all potentially curable treatments. And Dr. Pamela rightly also discussed the role of radiotherapy in benign lesions like AV malformations and acoustic neuromas. And some people have gone on to use radiotherapy for atrial fibrillation. They're called or even in epilepsy. So there's a lot of technology techniques, and please do not hesitate to talk to your radiation oncologist when the patient comes to you. And it need not be that the latest is always the best. I always say appropriate technology, appropriate technique, and appropriate dose. These are the three aspects which ensure cure and control. Thank you, Dr. Pamela, for a wonderful talk. And all three talks have been wonderful. And I wonder if the organizers would like some questions for each one of them, or we move on. If we do, then thank you very much to the IMA. It has been a proud privilege to be part of this meeting, and I learned as much as all of you. Thank you so much.
Yeah, thank you, sir, for moderating this wonderful session. And now we'd like to get some questions from our participants. You can just unmute yourselves and put up your questions to the speakers. Dr. Ibrahim, sir, would you like to add some more points?
Yes, sir. So it was a wonderful presentation in a very short time, and three important topics, that is surgical, medical, and recent advances in radiation oncology has been done, and it would have been loaded for the family physicians and all the audience here. So it's like personalized medicine now. So everything, including the radiation, everything, as Pamela Madam was telling. So in future, we may get radiation with biomarkers where the target tissue can alone be irradiated. So now it is like a combination of medical, surgical, and radiation oncology. So intraoperative radiation has come up, and intraoperative chemotherapy has come up. So many advances, so many collaborations have come up, and we would like to use them and educate all and general practitioners about the recent advances, so that the patient benefits from all these developments. And I should thank CGP for giving this wonderful opportunity where we were able to communicate and convey all the informations to the family physicians.
Yeah, thank you, sir. I think we don't have much questions from our participants. If any, we can just answer a few of them. So this program is...
I would like to,
yes, sir. Yes.
Yeah, I would like to ask Dr. Pamela Madam about intraoperative radiotherapy. So what's your take on intraoperative radiotherapy in some of the tumors like breast conservation surgery?
Yes, yeah. Intraoperative radiotherapy is another good one, because we would be actually, for example, in pancreatic cancers, like if we have done the surgery and we need to do the tumor radiation to the tumor bed, it is a wonderful thing to do, because we can move away the critical structures away from the radiation field, and we could use the linear accelerator to deliver an electron beam, one high dose of radiation, which can be given to that. It's also useful in re-radiation of rectal cancer recurrence after the initial radiation therapy. If they come with recurrence in the presacral region, for example, intraoperative radiotherapy also plays a role. In breast cancer, yes, the cavity can be irradiated with a mammocyte, or it can be irradiated with an electron beam too. So intraoperative radiotherapy, the radiobiology is different, because with a high dose, we are sterilizing the tumor bed.
Thank you, sir. Thank you, madam. Thank you. And to Dr. Patil sir. Patil sir is here, sir.
I think
Vijay Patil,
is
sir.
not online.
Okay. So most of the time we get a difficult situation where the patient would have been clinically diagnosed as malignancy, but the patient will be awaiting for the histology. So sometimes even we may need a immunohistochemistry. So sometimes it takes 5 to 7 days. So that is the most critical time. The patients and attenders will be very much in a tensed situation. They'll be asking whether it is malignant or not, like that. So I think in this critical scenario, the family physician should give lot of support, both psychologically as well as medically, to the patients and attenders, so that they are in a normal mood. Otherwise, this is the time where they may go for take a wrong decision and go for some other alternative therapy. Because always to take a correct treatment, we need the correct tissue diagnosis. Because the process takes 5 to 7 days. Maybe in future, we may get immediate diagnosis of the immunohistochemistry also. So these 7 days are very critical in decision making of the treatment modalities. So I think family physicians should take control and guide the patients appropriately at this juncture also.
Yes, sir. Very much true, sir.
Can I just make a comment? It's very well taken what you said, but I think we all should sort of think about a good communication skills with the between the doctor and the patient. So that goes a long way, even when you have to tell them about the diagnosis. Sometimes out of fear, they run away from the right treatment and they go try out everything. So a good communication between the patient and the doctor will go a long way in getting the patients treated at the right time.
Yeah, thank you, madam. So I think we had a very good discussion, and we are almost in the end of this session. So if there is no other questions, I think we can end the session with vote of thanks. Yeah, thank you. And now, closing remarks. So since our secretary, Dr. Anburajan sir, is held up in a emergency meeting, he is not able to attend today, but everything went on well. So there are totally close to 700 participants, and almost many of them have registered. If anyone has not registered, kindly register now with all your medical council details, and also kindly pay for the credit hours. So all the credit hours will be processed within 10 working days. So I request you all, if unregistered, but still you need a credit hours, kindly register immediately with the Google link. And the link will be active for further 1 week time, and we will get the certificates within 10 to 15 working days. And now I thank immensely all our resource persons, our moderator, Dr. G. Nagaraj, our speakers, Dr. Mohammed Ibrahim, Dr. Vijay Patil, and Dr. Pamila for the extensive talk, and which is very rare, and it's not easy to find such a kind of resources in the recent times. We hear many common problems, but these kind of avenues are little different and unique, and it is a good chance for every physicians to hear about this and at least have a thought on this. And I thank our Dean, Dr. Ramesh Babu sir, who has given his welcome address, and also our Joint Secretary, Dr. Dirve Mohan sir, our National President, Dr. Sharath Kumar Agarwal sir, our Finance Secretary, Dr. Sijit Bali sir, and Dr. Jayesh Leela sir, our National Vice President, for all their contributions for today's program. And not the least, all our participants who gathered in large numbers and participated actively throughout the session. I thank everyone. Thank you so much. So with this, we end the session. Thank you. Thank you, madam.
Thank you, sir.
Thank you. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, sir.